the field.
I would like to invite Eamon also. Dr. Mora, Sarah, please come on. Dr. Eamon Rahmani, please come on. And okay, so now this is open discussion. We have all the speakers are here. Any questions about this session, about any session, any unanswered question you want to ask our quality expert, Mustafa, Leah, and Faisal are here. Myself and Eamon on your disposal if you have any questions there. Hafiz, why you are sitting? Come on. Come. Okay, so you have one question. Please go ahead.
Thank you, Doctor. This
And,
is
and
for-
please, who are here, stay. We have a group photo with all of you in the end. Sridhar, come on. Viviano? Yes, go ahead.
So this question is for Dr. Faisal. Doctor, do you feel that having a perinatal network at an emirate level and eventually a national level is achievable? If not, what can be done to aid democratization of perinatal and neonatal services in our existing system?
Okay, I think I got the first question, but I'll probably ask you to repeat the second one.
Do you feel that having a perinatal network at an emirate level and eventually a national level is achievable?
I am sure it's achievable. I think the important first to actually have the framework and the policies as a standard across UAE. So if you have a national, framework where the definition, because currently, as you know, we have two main health authorities and we also have the Emirate Healthcare Service. So, and you can see they may use the same definition for us, say defining mortality and neonatal mortality or perinatal mortality, but they may have a different type of exclusion or inclusion. So I think first thing, let's get the framework right. Let's get all the processes and policies and the standard together the same. So then you can have a network where everybody actually looking at the same thing. Because the data is really important. And then you can, after that, you can have people actually come in, look at the process, everybody's doing the same. And I 100% is achievable. If you think about UAE, we only have 100,000 live birth. So it's not, we have, 2-3 million or something, yeah? So I am sure we can. If you're looking at the population currently, I think, is that 12 million or something?
Sure.
Yeah, so I'm just saying, yeah, we definitely, I think it's achievable.
Faisal, just 1 minute. In addition to that, we are having a very low neonatal mortality and this thing. So is the government give you any target that we have to achieve that? We cannot be zero.
Sure. I think we usually, as I said, working in hospitals, we think actually we can, especially if we work at level 3 or high, we said, oh my gosh, we had a lot of mortality. But we're talking about all birth, all live birth. Yeah? So the mortality is actually overall, if you look at a neonatal unit, you may have a high mortality, but that's not reflecting neonatal mortality overall, which is really important because thankfully, 9 out of 10 pregnancies are straightforward. Babies go home with the mother with no issues. So I think, it's something, yes, definitely. And I think the idea what it is, we need to look and have data, validated, standardized data. I mean, I know Leah was talking about the quality of the data. The quality of the data is really important. So then you can put it into analysis and everybody is getting the same data, the same process, and then you'll have a better outcome.
Yeah, Dua?
Thank you.
My question is for Dr. Faisal and Dr. Hafiz. Regarding, again, the limits of viability. For example, a baby who was born at 22 plus, but the weight is like 510 grams, baby was born very weak and was not offered resuscitation. Will this be considered as abortion or neonatal mortality? And whether resuscitation was offered and did not work, this will change the definition?
Valid question. I think the JORA KPIs which are coming your way will say exactly that. So if a baby was offered resuscitation and then died, it will be counted as a neonatal death. And if not, I think it'll be counted under stillbirth. That's my understanding. Faisal, if you can correct.
Yeah, I think honestly, any live birth from 22 weeks and above, it is count and died, and the baby shows sign of life and dies. That is a live birth, and that's a neonatal death.
Even if the weight is below 500 grams.
Yeah, I think that's really important. I mean, if it's 500, it doesn't matter what gestation it is. As simple as that. But after that, if you got a 22-weeker, there's two things. You're talking about corrected neonatal mortality. We know I'm talking about neonatal mortality overall.
Yes.
Yeah, it's really important. So if a
Yes.
patient showed sign of life, so if the baby is born at 22 plus 1, whatever, and it showed, say, 10 heartbeat over a couple of minutes, per minute, that's a live birth.
Okay.
So I think it's really important. The data is really important for overall to look at the whole service, look at what's happening in that sector. So I don't think it has to do, because currently Department of Health does not. I have not seen any data says the target should be 3.5 per thousand. It doesn't give you that. It's actually said lower is better.
Yes.
So that's really important. So I don't think we should think about limit of viability, because limit of viability, unless it's an IVF, you can have 2 weeks both ways. So I think what it is, you need to see the patient. You need to first have the discussion with the family beforehand, see the patient, know all the information, make the assessment in the delivery, and you provide the patient who are actually responding to basic stabilization, and the parents, in this country, the parents don't have big say of not giving resuscitation or stabilization.
So if the parents are keen for resuscitation for the 22 plus weeks, sorry, it went over to limits of viability. Shall we start to offer antenatal steroids starting from 22 weeks?
Well, the data we discussed earlier, the babies who have been, the 22-weeker who's been treated as same exactly aggressively like the 23-weeker, instead of 1 in 10 surviving, you will have 3 out of 10 will survive, not really different than a 23-weeker.
Yeah, so if you're focusing on survival focused care, yes, antenatal steroids is what people are heading towards. But it's still not on the local guidelines yet.
Yeah, so there is a guidelines from SAHA about what to do with borderline viable fetuses from maternal point of view and neonatal point of view. We can send it to you and share it with you. It doesn't address that much the steroid issue, because steroid issue is that debatable. But it gives you step by step what you need to do for 22 weeks to 23, 23 to 24. Whose responsibility, who's going to be notified, what's going to be the resuscitation. So we'll be happy to share it with you.
Regarding the steroid, is really important. There is observational study shows there is a benefit, observational studies.
So my question, before you come to, with this regard, and I will come back to you, Eviano, pointed to Sridhar and all of us, is a sensitive question, so don't take it personal. What do you think, the supportive care of very low birth weight, 22-weeker, you are long enough in there, and Hafiz, Faisal, Eviano, Amna, Ayman, anybody can, Mustafa can answer. Is we are ready for that?
I mean, it's a learning curve. This afternoon during lunch, we were discussing the same issue, that when we were in UK in 2005 to 2010, for example, we were not touching the 23-weeker. We didn't feel we were ready for it. But in the past 10 years, both in UAE and in UK, 23-weekers has become almost like what we faced with 24-weeker before. And when I was training in India, I mean, again, the age issue comes up, but when I was training in India in 1990s, 28 weekers was comfortable, but below 28 weekers, we weren't comfortable. So there is always a learning curve. There will be mistakes. I mean, for example, when we started managing our first 23, 24 weekers, we often faced chlorhexidine burns, or, Dr. Helmet presented isopropyl alcohol burn. So the skin is totally different, the need for humidification, the need for nutrition, how they tolerate feeds. I mean, we have the meconium inspission syndrome, so their feed tolerance
So
is
my
different.
question to you and Hafiz also, are we ready for that?
We need to learn.
Or
Unless
no,
we try, we
learning,
won't
I
learn.
know, learning is always never ending, knowledge is for sharing, this is my code, but are we ready for
No,
it?
I'm answering a question indirectly that we will not be ready straight away, but we are getting ready.
Hafiz, what is your take? And then I come back to Eviano.
At this point in time, the science is not entirely clear, let's put it that way. And it's, if you ask me personally, we are still finding our way through it.
Sure.
Yeah.
Eviano,
So I have a different take on it because, in the first instance, my first experience as a consultant in the UK was in a service where they aggressively managed 22-weekers. My question in my interview for that post was, why do you think we resuscitate 22-weekers? And my answer was, because you can. Because they could. They had been doing this for a while, and they were confident about doing it. Now, there are other issues that we need to talk about, including the issue of steroids. So even at that time, our team declined to give ladies steroids at 23 weeks.
but the thing is that what Hafiz present, that we want a survival only or we want an intact survival?
Correct.
That's the question.
It is, and it will
I
always
mean,
be the question.
Yeah.
It'll always be the question, and that
Like,
question,
sorry, I'll say, in 2017, me and Ayman invited that Japanese guy who is sending, is a 95% grade 1 or 2 or 3 or 4 IVH. I mean, total is 95% of those 21 weaker has IVH. So what's the point?
so I'll ask another question. The next question is, how many people here are actively performing neuroprotective procedures, protocolized, for their extreme preterms?
That's why I'm asking that, are we ready? Ayman, your take on it.
So I think the issue is not like we have to resuscitate because we can resuscitate in 20 weeks. But what's your outcome?
Correct.
So the question is, like, how many survivals in 22 weeks in your institution? Like in our institution, there's a survival of 22 weeks. And Dr. Mustafa has the picture, he's in contact with the parents. We have few survivors of 23 weeks, intact survivals also. So you need to know, I mean, I know it's learning curve, but you need to know what your institution is capable of doing, not because you can, but because of your outcome. The question is what for you?
For that, are we ready for
Yeah,
preaching?
Yeah, no, we are, we are ready to resuscitate 22 weeks because there are survivals, and we have survivals in our institutions, so we are ready. But, as for the mortality, I don't know, Dr. Dua asked about what's our mortalities. The JODA KPI will tell you that corrected mortality should be less than 1.5 per 1,000 live birth. Every country, they have their own infant mortality rate. US have mortality rate issued WHO, they have, for everybody. So our goal for the JODA KPI is 1.5 per 1,000 live birth. The problem is that you don't follow the babies after you go out from your institution, so you're underestimating the infant mortality because the baby might be going somewhere else and die there. But it's 1.5 per 1,000 live birth, which is very, very ambitious. I think compared to the, you don't agree? Okay. What's the infant mortality in the US, Dr. Ali? 8 to 9.
8 to 9. So, Sarah, after all this discussion you heard, okay? So do you think we will have a good neurodevelopment outcome?
I don't
Mine is
know.
gone, but I am talking about those babies.
Well, the other problem is that intact survival is in the eye of the beholder. So many of the children who we are about whom we are saying they are not intact are children with whom their families are very, very happy. And so, there are plenty of children with borderline IQs who are walking, talking, functional members of our society with jobs. Maybe they're not the same as they would have been if they had been born full term, but they're people just like the rest of us, and their families are happy with them. So we have to be careful about assuming that every child who's not classified as an intact survivor should not have survived. The numbers of children who are completely disabled to the point of being dependent on other people throughout their entire lives for their care is quite small. And so I think as we start to make decisions about whether or not to offer this therapy, we need to be thinking about survival and then severe disability differently from moderate disability, which really is a very different outcome.
Okay. Yes, Sridhar.
So, I mean, coming to the UAE scenario, obviously we have DRG system as well. And if you compare the money paid for a 22-weeker and a 24-weeker, it's exact same, unless you go for surgery and things like that. And you're looking at a length of stay which is like double, from 3 months to 6 months.
That's
and
what I'm
again, the outcome is difficult. So unless the hospital is willing to hold that and your unit is going to block a bed for that long, with an uncertain outcome. So if the parents are very keen, I think we are justified in offering because there are survivors.
Sure.
And again, in US, as Dr. Faisal said, there are studies which have looked at steroids, MagSelf, everything. And if you decide to go for full care, you can start with steroid and MagSelf right from 22 weeks.
Can I disagree with you, though?
Yeah.
So I totally disagree with this statement because we cannot really, design the medical care according to the macroeconomics. We cannot say that because you can afford to have care, we have to give it to you. But if you don't afford care, we're not going to give it to you. This is like kind of discrimination.
Yeah.
That's-
Mustafa want to comment.
I want just to share the experience at Tawam Hospital because we have many cases like this maybe in every week. We have to go to counsel families about 22 to 24 weekers and already you adopted the guideline. So in the guideline, they would, based on the sharing decision between us and the family. So the answer for Dr. Junaid, are we ready? At Tawam, yes, we are ready to give 22 weekers. But this will be a shared decision with the parents. Usually when we go to the parents, if we have 22 weeker, we'll come sad, we'll go there and we'll give them the impression that the baby will not survive. When we'll come with 24 weekers, we'll be with big smile. Okay, we have survivor right now, we are ready.
I think this is not only the doctors I am talking about. It
Yes.
is all over the thing. The nurses, the RTs, the
Yes.
environment, the OBGYN, and I know the
Yes.
data is not very good. If
This
you
is what
think.
we did.
We have a survival of 22, Faisal knows that, you have a survival, but can you combine it? Even the
Yes.
CHOPS data, what about your data of 22 weekers?
But I'm just to say, all the parents, or most of them, especially the national one, they accept that we want to resuscitate. This is they say. And sometimes they will bounce to you, okay, doctor, you are the doctor, you know better than us. Will be a huge responsibility for us.
So you know better
We
than
said-
them, na? You know there is a grade 3 IBH, you know there is a BPD,
Yes.
you know there is
Yes,
a neurodevelopment
this
outcome.
is what we try to show them, and we already have data in our hospital. Maybe we'll publish next month. We share them in all data. We told them everything, and then they said, okay, go for everything. Then what we can say, we say, okay, so we'll go for everything, but you have to know, sometimes we cannot stick the tube in. The baby will be so small. Sometimes during the physical exam will be baby below 22
Sure.
weeks, will not do, and the change in the
Yeah,
plan will
Faisal,
be at
your
any time.
comment,
I just
or your
want-
comment on
just
that,
one-
and
one-
then Leila.
One comment. We're spending a long time talking about 22 weekers. The number of 22 weekers are become alive to a neonatologist so minute, even of a total extreme premature babies. Majority will die before they arrive or die during in the postpartum. So I think we just need to be pragmatic about this.
Okay.
Assess the baby, lucky assess a 23-weeker, offer the one who's actually responding to basic resuscitation, early resuscitation.
Can I just
fair,
add
counseling,
something to
Yes,
that?
Leah. Yeah, go ahead.
Yeah, so all I was going to say is from the perspective, Sarah and I both work at an institution where we do offer resuscitation to 22 weekers, and as you were just saying, and I completely agree, despite the fact that it's something that is a routine part of our practice now in offering to families if they desire it, we counsel in a very similar way because our outcomes are not promising. And so the majority of those children will still die, and many of them will have long-term effects, despite the fact that it's something
Sure.
that we now have integrated into our practice.
Yeah, Leila.
Jeanette, before answering your question, I mean, how do we know if we gave steroid for 22 weeker, there might be better outcome. What I'm trying to say, I agree with Sarah and I agree with other lady as well. Because did we do everything we can do for this baby? Okay, we cannot do a lot to prevent premature delivery. I mean, we're trying, but maybe in future things will become better. But when the baby is born, we are still far behind better tools to monitor, better tools to take the care of the baby from the beginning. We're still arguing about if positional midline head is better or not better. There's a lot to learn for these babies to take care from the minute they are born until they reach terms. We are not even there. We are not even using the tools in the monitor, looking at the histogram, the trends, you know. We have not done all of that. And as the lady said, like, you know, maybe the family will be happier. There's a lot we need to apply when the baby is born to decide if this question can be answered or not.
So I think, Leila, this is your duty to counsel the parents and tell about that. And
I'm not talking about counseling. I'm talking about our job when a low birth premature baby is born. There's a lot we are not doing from the beginning. We just started now doing physiotherapy or positional therapy from the minute the baby is born. The minute he's stable, we start doing physiotherapy, and we are seeing different. We are now we are applying tools where we measure at least motor activity. You know, measure when the baby is born. You know, apply the position and whatever, you know, exercise we do, and then later on. And if you just want to come and hear the parents, these parents were with their babies from the minute they born. I'm talking about 23-weeker, 24-weeker, 22-weeker sometimes, you know. They see the baby when they are in the unit and few months afterwards. Applying the right tools, not only for making things better, you know, moving the baby, you know, as soon as possible, it made a difference. We are not doing that. We're doing it in certain places. I think until we reach that stage where we do more monitoring, understanding definition, we cannot even decide PDA significant or significant until now because we don't have the right tools. People are actually arguing with me why I'm doing ultrasound lung when I'm doing echo. Because real-time evaluation of the baby can give you a lot of information. We're not there yet.
This is already, Hafiz and Siri, they're saying we are on the learning curve. Of course, we have to learn, and this is no doubt about that. And Faisal and Leah is also telling the same thing. You have to evaluate the thing. Yes, Dua, anything?
No, but just I want to ask you your opinion, Dr. Junaid, about the resuscitation 22.
That's good one. Okay, because I ask everybody opinion. My opinion is the same. 22-weeker, if they called me 2 a.m. in the night, I will go, I will, you know, assess the patient, and then I will tell the parents how it looks like, if they want it or not. Because many times these babies, as Faisal said, during the process they die, okay? And let's say if they survive with the, what I don't want, the baby with the grade 4 IVH and the BPD and all those and the survive handicap. This is what I don't want. So I really take my time to evaluate the baby and tell the parents that what I should do.
So, Dr. Abid, Dr. Abid.
Yeah.
So I'm sorry that I'm confused now. So what do you want us to do? You said we're not ready? So, okay, so now let me just tell you. If you're not ready, maybe we should get ready.
I wish, yes.
Okay, good.
I am getting ready. We have a physiotherapist in our unit. We need a proper nutritionist. We need early intervention from the first minute the baby in the unit. We need to teach our nurses how to position the baby. We need to apply neuroprotection in our units. There's a lot we need to do.
Yeah. So this is what Dr. Eviano suggested, Yani. If you have your neuroprotection bundle for extremely low birth weight infants, this will improve your outcome.
Sure.
But can we wait until we get all this that Dr. Abed wants to do before we start resuscitating 2 or just?
No.
Okay, very good.
Okay.
Faisal wants to say something.
Just something to Dua really was interesting. So if you look at the data from, I think it's Edward Bell, from looking at all babies below 28, from 22 to 28 weeks, was published 2022. And then out of that, there were around almost, 550 babies, 150 or 160 were admitted to NICU. If they survive the first 12 hours, then their survival increases to 80%. So it's the first, really the beginning, like you said, if they antenatally had a better support during intrapartum, and they also had the steroid, and they also had max sulfate and the antibiotic, and aggressively maybe had C-section if required. These babies, and managed well by neonatologists, the only problem with us, we don't know what to do with 22-weekers like we do with 23-weeker. We do too many things. And they are really different. So my point of view is sometimes hands-off and not being aggressive, looking for that blood pressure of 24, 23, and doing these things, and leaving that baby alone. If they survive the first 12 hours, the survival goes up to 80%.
Yeah, Hafiz?
Just wanted to add, we've been focusing so much on the hospital care of these babies. And we are comparing what's happening in the US, UK. What we don't have here is once they go out of hospital, the supportive services these babies need. For example, like the organized BPD program, which Sarah runs in CHOP, the developmental surveillance which goes on, the occupational therapy, physiotherapy. I've seen even Emirati parents struggling to get the right services for the extreme preterms, leave alone the rest. So I think it's not just us neonatologists who make a difference to these outcomes. There's a whole lot of people out there who's needed to support these.
That's I want to listen since morning. This is not only the doctors who should decide. This is a lot of things, lot of regulation. Mustafa, last comment, because me and Ayman are very tired now.
Good. So I think the key point here is to keep all the team mentally prepared that this patient will survive or may survive, we'll say. We have few survival last few years, and we keep in touch with this patient and keep sending photo for us, sharing with all the team, RT nurses. This will encourage them to change the attitude toward this 22-weeker, and for antenatal steroid, whenever in our hospital, whenever we decide to go for resuscitation, we offer neonatal antenatal steroid. Thank you.
Okay. We have to